All right, welcome to The Explainer. Today, we're diving into a paper that's really important for anyone working in UK emergency medicine, the ABC Sepsis Trial. It takes a hard look at something we do every single day. Let's get right into it.
You know the drill. Every single shift, you've got a patient with sepsis who needs fluids, and they need them fast. We automatically reach for crystalloids, but the guidelines, well, they've always kind of dangled the option of albumin in front of us. This paper really asks the question, have we been getting it right all along?
So, here's how we're going to break it down. We're going to follow the structure of a proper critical appraisal, which, by the way, is perfect if you're prepping for FRCEM. We'll kick off with the clinical dilemma and the trial's big results, then we'll really get into the weeds of its internal and external validity, before we land on a final verdict for our own practice.
Okay, so to set the scene a little bit, let's just quickly remind ourselves where we stand with sepsis fluid management. It's a landscape that we all know pretty well, but if we're honest, it's always felt a little uncertain. This is the standard playbook, right? Crystalloids are king. Albumin is something we think about when a patient needs massive volumes of fluid, and usually that's a decision made upstairs in the ICU. But here's the kicker. That evidence, it's all from ICU. What about those crucial first few hours in the emergency department? Well, that's the exact gap this trial was designed to look at. Does albumin have any role to play with our early, undifferentiated sepsis patients? We're all busy clinicians. We need the bottom line up front. So, before we get bogged down in the nitty-gritty of the methodology, let's just cut straight to the chase. What did they actually find? Now, this is absolutely key to understanding everything else we're about to discuss. This was primarily a feasibility study. Its main job wasn't to definitively prove that one fluid was better than the other. It was to see if you could even do a massive definitive trial like this in the crazy, chaotic environment of 15 different UK emergency departments.
Okay, let's get into the numbers. First up, the control group, the patients who got our standard care, which was balanced crystalloid. Their 30-day mortality was 14.8%. So that's our baseline. And now for the intervention group, the ones who received 5% albumin. Their 30-day mortality was 21.1%. Yeah, that is a pretty noticeable jump, and probably not in the direction anyone was expecting.
And seeing it like this on a chart, it just drives the point home, doesn't it? When you put them side by side, you can see that clear numerical difference. There's a definite trend towards harm in the group that got albumin.
So, what does this all mean in plain English? Well, the odds ratio of 1.5 suggests the odds of dying were about 50% higher in the albumin group. But, and this is crucial, look at that confidence interval. It goes all the way from 0.84, which would suggest a benefit, up to 2.83, which suggests pretty significant harm. And because it crosses that magical number of 1.0, we just can't rule out that this result was all down to the luck of the draw. It's a signal of harm for sure, but it's not statistically proven.
So we've got this signal of harm, which is pretty concerning. And that brings us straight to the heart of any good critical appraisal. Internal validity. In other words, was the study actually done properly? Can we trust this result?
Look, on the one hand, this study has some serious strength. It's a multi-center RCT, our gold standard, and you have to take your hat off to the investigators. They actually managed to recruit to target in the ED, which is just notoriously difficult. But, and it's a big but, there are some weaknesses. It was open label, so doctors knew what fluid they were giving, which could have introduced bias. And more importantly, there was a lot of crossover between the groups.
And honestly, this right here is probably the biggest red flag for the trial's internal validity. A full 22%, that's more than 1 in 5, of the patients who were supposed to get albumin also got crystalloid in those first 6 hours. Now that completely muddies the waters. Why did that happen? Were those patients sicker? Did the clinicians just lose their nerve with albumin? We don't really know, but it makes interpreting the results very, very tricky.
Okay, so let's just park the methodology issues for a second. Let's assume we can trust the results. The next big question is, does this even apply to our patients? Do the people in this trial actually look like the people we see every day in our own EDs? And when you look at who they actually studied, the answer is a pretty resounding yes. The average age was 69. The median NEWS2 score was 8. These are sick patients. Median lactate of 2.2. But here's the clincher for me. Only 13% of them ended up in ICU. This is our typical elderly, comorbid sepsis patient that we manage on the wards, not necessarily the person in florid septic shock who's going straight to intensive care.
And if you look at where the infection was coming from, yep, 60% chest infections. This is the bread and butter of any UK emergency department. This strongly supports the idea that, yes, these findings are very relevant to the patients we see day in, day out.
Now, this is a fascinating little detail that I think is really important. We all know the 30 mils per kilo mantra for sepsis, right? But what actually happened in this trial was much closer to reality. The median volume of crystalloid given was just under 18 mils per kilo. This probably reflects a more cautious, real-world approach to fluid resuscitation that many of us are taking now. It's really important context.
Right. We've chewed over the results, we've picked apart the methods, and we thought about how this applies to our own patients. So let's pull all this together. What is the final verdict for our practice in the emergency department? Sometimes the most powerful summary comes straight from the horse's mouth. The authors themselves wrote this, and they basically said, look, we proved we can do a bigger trial, but we're pretty sure it's not going to show any meaningful benefit for albumin. That is a really, really powerful statement to make in your own paper. So if you're ever in an exam or a teaching session and this paper comes up, here's your 4-point knockout summary. Simple. 1. State the finding, a feasibility trial with a non-significant trend towards harm with albumin. 2. Critique the internal validity. You have to mention that 22% crossover. 3. Discuss external validity. It's a very relevant patient group, but the fluid volumes were pragmatic. And 4. Conclude that the signal of harm just makes a bigger trial very unlikely to show a benefit. And that really leaves us with the million-dollar question, doesn't it? We have a treatment that's way more expensive than the standard of care, that showed zero evidence of benefit, and in fact showed a pretty concerning signal of potential harm. So for the vast majority of our sepsis patients in the ED, is this the final word? Is it time to finally close the book on albumin? It's a very compelling thought to end on.